Welcome. Welcome, Dr. Ramesh. Before I introduce my dear friend and colleague, I would like to start with a land acknowledgement. As this is a hybrid event, some participants are on different territories, so please take the time and space to give thanks and gratitude and respect to the land you are currently living and working on. Today, we are here at York University campus in Toronto. York University is situated on the traditional territory known as Tkaronto, and we acknowledge its current treaty holders, the Mississauga of the Credit First Nation. We also acknowledge that this is the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As we discussed last time, the land acknowledgement shouldn't be the end of our truth and reconciliation, and I've been doing a lot more reading about Treaty 13, Treaty 22, and Treaty 23 that ceded the land to the Crown that we now live on, and all of the irregularities with those treaties. So I encourage us all to become familiar with the story behind these treaties and to keep an eye on the court cases that are still ongoing, and the early settlement that we talked about last week of $30 million to begin some sort of reconciliation with how irregular those treaties were. The government is admitting that there were real problems with those treaties. So it is ceded land, unlike large parts of, for example, BC, but ceded under very unclear and conflicting agreements about what that meant and who was involved, what they thought they were agreeing to. So I know that University of Manitoba has an incredibly strong link to the many Indigenous communities in that area. And I had a really wonderful experience when I was there visiting Ramesh and his team, where I did get to learn a little bit more about their Indigenous faculty and health programs. So moving on to our very exciting talk today, it is my absolute pleasure to introduce Dr. Ramesh Banadakoppa Manjappa, who is an assistant professor at the Department of Community Health Sciences and Assistant Director, Research and Knowledge Translation at the Institute for Global Public Health within the Max Rady Faculty of Community Health Sciences at the University of Manitoba. He is also a founding member of the India Health Action Trust. Previously, he was the project director for the University of Manitoba's Maternal, Neonatal, and Child Health projects in Uttar Pradesh and Karnataka, both states in India. He was also the director of the Population Research Center, Dharwad, also in India, and a faculty at the International Institute for Population Sciences, Mumbai. Ramesh is a demographer by training with a long experience of over 30 years of research and program implementation, monitoring, and evaluation in the field of maternal, neonatal, and child health, and HIV/AIDS. And on a personal note, I will say that Dr. Ramesh is one of the most brilliant methodologists and statisticians I've had the pleasure of working with, and has incredible ability to use mixed methods in his work. He's also somebody who brings an incredible groundedness in community processes and experiences from his work, primarily in India, but also in many other countries. And he's really seen that link between policy and impact at the front lines. And finally, he's been a mentor to me over many years now, and is somebody I really look to on leadership and how to run a collaborative team across many institutions. So it's really just so exciting to have him here, and I'll turn the floor over to Dr. Ramesh.
Thank you very much, Kerry, for those really nice words and kind words, definitely. And it has been a pleasure to know Kerry and work with her and on the project that I'm going to talk about today. And thank you so much. And greetings from Winnipeg, and good afternoon to you all. So today I'll be sharing with you some of the key lessons that we had from India's progress in improving maternal and neonatal health at the national and cluster levels, This was a part of a greater study on the maternal, newborn, and child health exemplar in India. And I had the pleasure of working with Kerry, along with other colleagues, Andrea Blanchard and me. We three of us were really, leading the analysis, interpretation, and synthesis of results along with our colleagues in India. So that was really a wonderful experience to also kind of get the qualitative side, which qualitative research aspects, and also community and human rights perspectives that Kerry had brought into this our analysis in the study. And thank you so much, Kerry, for that. So today I thought of sharing with you a bit about the overview of the study that I was involved in, and my talk is based on that study, and also to say why India is an exemplar and what did India do basically to be an exemplar, and also the lessons that we learned throughout this study. So the India MNH exemplar study is a part of the Exemplars in Global Health Initiatives, which is funded by the Gates Ventures, which is different from the Gates Foundation that we know of. And this approach applies the positive public health approach for learning from contexts where exemplary success has been achieved in improving population health. The MNH exemplar study aimed to document drivers associated with rapid reductions in maternal and neonatal mortality over the past 2 decades in a diverse set of countries that experienced greater than average declines. So globally, we had 7 countries identified as exemplars in MNH, with faster than expected reductions in maternal and neonatal mortality since 2000 relative to their per capita income. These 7 countries included 3 from South Asia, Bangladesh, Nepal, and India. So in terms of methodology, the India study team employed a mixed method approach, as Kerry was saying, that integrated quantitative data analysis with interpretive understandings from documentary sources and key informant interviews to develop explanations for NMR and MMR reduction. So based on an integrated conceptual framework and existing evidence, we quantitatively examined trends in mortality reductions and related drivers, and qualitatively explored the underpinning health policy and systems levers nationally in 2 state clusters and 6 selected exemplary states. The research time period covered 2000 to 2021 overall. And for quantitative analysis, we used multiple data sets, such as the sample registration system, which is a unique data system in India, which is a dual record-based system wherein a resident part-time enumerator does a continuous enumeration of births and deaths in a sample of villages, urban blocks, and then independent 6-monthly retrospective surveys conducted by a full-time supervisor. So this is a kind of a system that we have for both mortality and fertility estimates at the national and state levels, rural and urban areas. And this data is generally it's available from 1971 onwards. Every year we have these SRS estimates available. So that's a very rich data source to understand the trends in maternal and newborn mortality, which was the key subject of our study. The other data sources that we used included nationally representative sample surveys, such as the National Family Health Survey, which we had 5 rounds of National Family Health Survey. These surveys are in design and implementation similar to the demographic and health surveys that you might be familiar with. In addition to NFHS, we had district level household surveys. We also used the estimates from UN Interagency Group for Mortality Estimates, Global Burden of Disease Study, basically for causes of death trends, and Million Death Study for the causes of death trends. So the sample registration system data was used for assessing the maternal and neonatal mortality and fertility trends. And we used the pooled data from national household surveys for the including 5 rounds of NFHS and 3 rounds of district level household surveys for intervention coverage and equity analysis. For qualitative analysis, we conducted desk reviews of published and lay literature on policies, programs, health systems and services, and contextual factors. We conducted key informant interviews and 7 roundtable discussions with key stakeholders among government officials, NGOs, professional associations, financial and technical experts, private sector, and our program implementers nationally and in 6 states. I must acknowledge here that Dr. Kerry Scott was a key person in designing and conducting most of these key informant interviews and also the roundtable discussions. Another approach that we used in India is, as we all know, India is a diverse country with a population that grew from 1.1 billion in 2000 to 1.4 billion in 2022. And considering India's size and diversity, it's important to understand how the improvements in MNH in India have followed different trajectories and momentum in the heterogeneous states and regions. So to characterize, compare, and understand states' different mortality transitions over the past few decades, we identified 2 clusters of states using empirical data on mortality trends by per capita income. We mapped all major Indian states according to their mortality rates and per capita income in 2000 and 2018, and the states were clustered into 2 clear groupings. One of higher mortality states with lower per capita income in the light blue color in the map shown here, and one with lower mortality states with a higher per capita income, dark blue states. So the state clusters were then used to select specific states for in-depth study. 2 states, Maharashtra and Tamil Nadu, we chose from the lower mortality state cluster, and 4 states, Rajasthan, Uttar Pradesh, Madhya Pradesh, and Odisha, we chose from the higher mortality state cluster for in-depth analysis. Another approach we took was to kind of define the different policy changes in India with respect to maternal and child health. So to guide this mixed method analysis, we divided the policy time periods in India into 4 intervals: the child survival and safe motherhood between 1992 to 97. Then we had reproductive and child health, RCH1, between 97 to 2005. Then we had National Rural Health Mission, reproductive and child health 2, that is NRHM and RCH2, and then National Health Mission and RMNCH plus A, 2012 to 2020. And it's continuing. So India's health policy focus has expanded from near exclusive focus on fertility reduction to increasingly broader programming for maternal and child health with an explicitly pro-poor focus. While the CSSM, the Child Survival and Safe Motherhood policy period, brought efforts to reduce maternal tetanus and anemia and create secondary level maternity care facilities called first referral units, it was found to have limited impact on maternal health. RCH2 NRHM redoubled the government's healthcare focus on safe motherhood and expanded consideration to neonatal care. And RMNCH plus A NHM period expanded to a continuum of care model, where offering a basket of essential services from the community to tertiary level across 5 life stages of reproductive, maternal, newborn, child, and adolescent health. So these different policy periods had a different impact on the trends in mortality as well as other proximate determinants such as intervention coverage. So that is the reason why we were keen to understand the trends, the quantitative trends along these policy timelines. So the study had a lot of partners, both international and India-based partnership. So within India, the key institutions that are involved was the National Health Systems Resource Center, which was a technical support unit to the Ministry of Health and Family Welfare, Government of India, which actually led a lot of qualitative research part of the study, especially looking at health policies and programs and how, and also related to the data available in terms of infrastructure, HR, and other key inputs to the programs. Then we had International Institute for Population Sciences, which led the quantitative part of the study because they were also the key implementers of many of these national level surveys like NFHS and the DLHS. So they were naturally the leaders in analyzing this kind of a data. Then University of Manitoba's Institute for Global Public Health, to which I belong, and the India Health Action Trust, which is our NGO partner in India. Uh, these two organizations provided technical support and coordination of the implementation. And the steering committee provided leadership, support, technical support, and review and agreed to the protocols and state selection, facilitate engagement of stakeholders, interpret the results, and promote communication of findings. I want to emphasize here the importance of collaborating with the government institutions, both the National Health System Resource Center and IIPS. They are the government-owned institutions. And when we approached the Government of India, they said that let us collaborate with the local institutions and partner with them for this kind of a study. And this was important for us because, and even the steering committee, it's important because the government was involved in the at every stage of the study implementation. But then they also kind of provided support in terms of data and the key informant interviews that we did. So there was a big support from the Government of India and an uptake of these findings and the recommendations that we make from this study. So why is India an exemplar? India stands out clearly as an exemplar country for its reduction in maternal mortality over the last several decades. As we see here, the sample registration system data shows an MMR decline from 327 to 103 maternal deaths per 100,000 live births between 2000 and 2018. While maternal mortality has experienced a steady decline overall since 2000, progress accelerated slightly during the RMNCH plus A NHM period at an average annual rate of change of minus 8% between 2012 and 2018. So this graph, we can see at the bottom, we have these policy periods and also the average annual rates of change for the maternal mortality during these periods. So this trend was particularly strong for the higher mortality state cluster, which is this on the top line, and which experienced an AARC of minus 9% during the RMNCH plus A and NHM period. The gap between higher and lower mortality state cluster narrowed substantially between 2000 and 2018, decreasing from 263 to 76 maternal deaths per 100,000 live births. This graph is similar to the previous one. Here we have the neonatal mortality trends for India and state clusters, and also the different policy time periods and the average annual rates of change here on the top right. So India's SRS data shows a reduction in NMR from 43 to 23 neonatal deaths per 1,000 live births from 2000 to 2018. Similar to MMR, declines in NMR have been steady over recent decades, with the most rapid gains experienced during the 2012-2020 RMNCH plus A NHM period, during which the AARC was minus 4%. While progress has been steady in both the higher and lower mortality state clusters, the gap between the clusters has stayed consistent over the years. This has resulted in ongoing lag in progress between the state clusters as they continue to progress. With the levels of NMR in the lower mortality state cluster generally about 12 years ahead of the levels of NMR in the higher mortality state cluster. And that's why we like to say that India has two exemplars, and they're following at different trajectories of mortality declines, and so it's important for us to study what each of these clusters did to achieve this exemplary progress. Another way of looking at this is also to see in a combined way both maternal and neonatal mortality against a transition framework, which the study team, the global team, developed this framework based upon the population data from 149 countries to track how mortality shifted from high towards low levels and shifts in some of the key related features of transition, such as timing and causes of mortality, coverage of life-saving interventions, inequalities in coverage and mortality, and fertility levels. So if you see here in this graph, the outer corridor or a segment that we can say is level 1, where both maternal and neonatal mortality is very high, and then we have stage 5, where both the maternal and neonatal mortality is very low. So stage 1 in the model is characterized by having the highest levels of maternal and neonatal mortality. The deaths are mainly caused by infections, health service access is low, and inequalities are large, and fertility levels are high. So this is again based upon the 148 countries when they were at this stage. So these were the characteristics of the stage that, high deaths and caused mainly by infections, and health services access being very low, inequalities very large, and fertility levels are high. Moving across stage 2, 3, and 4, it indicates that deaths are increasingly attributed to health status causes, for example, prematurity, congenital causes, and improving health service access, and increasingly high quality health services, shifting from top to bottom inequality and lower fertility. So stage 5 suggests the lowest possible maternal and neonatal mortality, wherein almost all preventable deaths are eliminated, and mothers and newborns have universal access to health quality care and high quality care, and fertility levels are low. So this is a little complicated, it looks, but what I wanted to emphasize here is that the India scenario it has been very impressive in the sense that India has made a transition since 2002, and even the two state clusters have transitioned. So progress is even greater for maternal mortality than neonatal mortality, which is typical for many countries that we have studied. And while the two state clusters started at different baseline mortality levels, both continued remarkable declines across MNS transition stage in the past 2 decades. So from 2000 to 2018, higher mortality states transitioned from stage 1 to 3, whereas lower mortality states transitioned from stage 2 to 4. The lower mortality states have a 12 and 16-year lead ahead of the higher mortality states in maternal and neonatal mortality transitions, respectively. So this gives us a sense of India having two exemplars, as I was telling previously. So what did India do to achieve this kind of a remarkable declines in mortality? So we all know a variety of factors contributed to India's progress in reducing neonatal and maternal mortality. So for this study, these interrelated factors were mapped into a conceptual framework that consolidated factors from existing evidence and frameworks, which included categories of distal, intermediate, proximate, and impact variables, as you see in this figure. So in the next part of this presentation, I would like to highlight the progress on key proximate drivers, especially with regard to intervention coverage and fertility decline. First, it appeared from our analysis that fertility decline has contributed to mortality reductions in part by influencing related risk factors. And India's decline in fertility itself, in part, has been linked to trends in proximate factors such as contraception access and uptake, as well as age at marriage. So these are the two important contributions, even for the fertility decline. So importantly, shifts in intermediate and distal factors such as women's education, employment, socioeconomic status, and other social determinants have also influenced the country's fertility rate. These factors contributed to evolving social norms around having smaller family sizes, evidenced in reductions in the total fertility rate. In this case, so if you can see in this graph, total fertility rate is defined as the number of children a woman would have if she were to experience the prevailing fertility rates at all ages and survive through her childbearing years. And we see that between 1990 and 2019, the total fertility rate in India has halved from 4 to 2 births per woman. And despite differing baseline levels, the higher and lower mortality state clusters showed similar trajectories of decline with respective fertility levels at 5 and 3 births per woman in 1990, which decreased to 3 and 2 births per woman by 2019. And which is not shown here, the data is not shown here, but we have analyzed and we presented the data, which shows that the most of these declines in total fertility rate is attributable to declines in fertility among the younger women, 15 to 19 and 20 to 24. There was a 71% decline in the 15 to 19 year age group, the fertility decline, and 40% decline in the 20 to 24 age group. So which was very impressive. That was contributed largely by increased age at marriage and also increased access to family planning. Another thing that comes when we talk about fertility is that declining fertility has also consequences for broader health system. Say, for example, while India's fertility declined, the number of births has stayed relatively steady in recent decades as a result of population momentum. So consequently, what happens is that maternal and newborn health programs have been able to focus on a relatively consistent number of annual births. We estimated around 25 million births India had to take care of for providing all the care that's related to 25 million births. And it has to keep pace with the growing number of births per year. So although fertility declined in both the clusters, population momentum was different. For example, the number of births in higher mortality states increased from 15 to 16 million between 2000 and 2019, while it reduced from 11 to 10 million in lower mortality states. And fertility decline may also be associated with a shift in the age parity distribution of births that reduced maternal and newborn mortality risk. Since risks tend to be higher with younger maternal age and higher parity. So, I mean, one of the key factors for the mortality reductions in India has been the fertility reduction. And how do we assess the impact of this fertility decline as a contributor to NMR and MMR reduction? For this, we used Jane's decomposition method. And accordingly, between 2000 and 2018, fertility decline was estimated to account for 29% of the reductions in NMR and MMR. I'm sorry, I'm not able to go into the details of the methodology, but what it means, what is telling us is that declines in fertility levels were associated with around 500,000 fewer neonatal deaths and 40,000 fewer maternal deaths in 2020 that would have been expected if fertility levels had remained constant since 2000. The decomposition approach also attributes the remaining portion of the mortality reductions to safe motherhood initiatives, a term used to collectively refer to intentional interventions that target maternal and newborn health. Together, this suggests that fertility decline and improved coverage of safe motherhood initiatives led to 1.1 million neonatal lives and 98,000 maternal lives saved in 2020, compared to what would have happened if the fertility rates and intervention coverage levels remained constant since 2000. So this finding highlights the impact of fertility decline as a key driver for NMR and MMR reductions in India in tandem with other healthcare indicators commonly associated with fertility reductions. Moving on to these, the other proximate determinants in terms of the intervention coverage. We looked at several intervention coverage indicators and equity. One of the key things is the antenatal care coverage. So over the last several decades, as we see, antenatal care coverage has increased rapidly. And progress in any ANC coverage, meaning that a woman received at least one ANC visit, was particularly pronounced during the RCH1 policy period from 1997 to 2005, as shown in the figure. Although many factors contributed to India's increased ANC coverage, a new cadre of community health workers introduced in the mid-2000s called Accredited Social Health Activists, ASHAs, you might be familiar with this cadre in India, has been identified as a key factor. In one study, visits by ASHAs during pregnancy was associated with a 17% increase in any ANC coverage. ASHAs identify pregnant women in the community, promote antenatal care seeking, and even escort women to ANC clinics. ASHAs are also compensated through a results-based financing scheme that includes incentives related to coordinating local ANC. So from our document and policy reviews, as well as our key informant interviews and roundtable discussions, the introduction of ASHAs at the community level has been one of the key features of India's program, which could have contributed to the increased coverage of many of these key MNH interventions. The other intervention coverage we looked at is institutional delivery. One of India's most impactful shifts in maternal and neonatal health over the last 3 decades occurred between 2005 and 2012, as we see here in this graph, during the RCS2 and RHM period when the government prioritized the promotion of institutional delivery. Previous national health policy periods had included efforts to strengthen the community, the capacity of traditional birth attendants in an attempt to make home delivery safer. However, during the NRHM period, skilled birth attendants training for providers such as auxiliary nurse midwives and staff nurses improved the capacity of health workers to manage uncomplicated deliveries in health facilities and refer cases with complications to higher level facilities. The NRHM also introduced the Janani Suraksha Yojana, a cash incentive scheme, which provided the financial incentives for mothers who delivered in facilities, as well as the ASHAs who supported institutional delivery. The same study that found contact with an ASHA increased the likelihood of a woman attending ANC also found that exposure to an ASHA was associated with a 28% increase in the likelihood of giving birth in a facility. These initiatives catalyzed major progress on institution delivery coverage from 26% in 1990 to 90% by 2018, as shown in this figure. This period also saw a particularly rapid reduction in the institution delivery coverage gap between the higher and lower mortality state clusters, which decreased from 29 percentage points to 11 percentage points. So there was a huge gap initially, in the 1990s, and then we see as we increase the institution delivery, the gap between the two clusters have also come down. The other aspect is the C-section rates in India, and in line with the increases in institution delivery coverage, C-section rates in India have also increased steadily with substantial growth, especially during the 2005-12 RCH2 and RHM period, as shown in this figure. I would say that especially during the RCH2 and RHM period, the country's C-section rate nearly doubled from 9% to 16%. Much of this increase was driven by increases in C-section rates at private hospitals. What did India do to increase these C-section rates? Basically, in the public sector, the subset of existing community health centers like CHCs were upgraded to become first referral units, which helped bring comprehensive emergency obstetric and neonatal care including blood transfusions and C-sections for settings beyond hospitals. These were established in the late 90s with operations streamlined during the RCH2 and RHM period. And then to help fill specialist provider positions at FRUs, India established skills training programs for generalist doctors, specifically targeted to teaching CMONG skills, including life-saving anesthesia skills to enable C-section. So there were, kind of intentional policy and programmatic inputs to increase the capacity and accessibility of the C-section and the comprehensive emergency obstetric care. Along with the increases in coverage, the equity has also improved. So in this slide, we show trends in equity in the coverage of key MNH services between urban and rural areas. And we see that no indicators saw expansion of gaps in coverage between the urban and rural areas, and rural populations in higher mortality states have greater increases in coverage in recent years. And in this one is showing the equity between the rich and the poor populations. And here also we see that nowhere the gaps have increased. They've all narrowed, the gaps are narrowed. But we see that the rich-poor gap is greater than the urban-rural gap that we see here. And poorer populations in higher mortality states have greatest increases in coverage in recent years. And although the existing equity gaps in intervention coverage have been narrowing, we still find substantial gaps, which means that we need further efforts to reach universal coverage. The last section of my talk today, lessons learned. I have a couple of slides. I know I'm running out of time, but if you can allow me another 5 minutes, Kerry, if that's okay.
Absolutely.
So one of the things that we observed is that India's exemplary progress on maternal and newborn health is a story of success largely driven by government services. So the public sector is the primary provider of maternal and newborn health care. The share of deliveries among all institutional deliveries that occurred in public facilities increased from about 47% in 2000 to 70% in 2018. So in absolute terms, 88% of the increase in institution deliveries in India occurred in the public sector between 2005, 6 and 2019-21. And with the increases in coverage, especially the public sector deliveries increasing, NMR has declined in both public and private sector. It's data I'm not showing here, but we have done the analysis to show that both, so they're comparable, public and private sector. We don't, we would have expected, okay, public health facilities probably experience more mortality than private, but no, they are more comparable at around 23 neonatal deaths per 1,000 live births in both public and private facilities. But what we saw earlier is that since health facility deliveries more than doubled in the public facilities, this shift trying to lower mortality risk settings, because when you double the institutional deliveries in the public sector, you are actually attracting more and more low-risk women into these deliveries. So this would have an impact on the overall NMR. So comparable NMR of 23 in both public and private sector is impressive to that extent. The NRHM and NHM brought the most accelerated improvements in access to public health care, particularly through various pro-poor schemes such as the JSY and JSSK. So one of the learnings from this study is that the government of India needs to retain its focus on public sector. Not only the public sector has expanded coverage of MNH services, it also has reduced the financial burden on families. So this is the NFHS data on the out-of-pocket expenses for deliveries for both C-section and vaginal deliveries in the public and private sector. And we see that the average out-of-pocket cost paid for delivery was greater in private than public health facilities, both for vaginal and C-section deliveries. And while out-of-pocket expense in public health facilities, both for vaginal and C-section deliveries, reduced over time, it increased for private facilities during 2015-16. So going forward, the government must continue to position itself as a primary provider of maternal and newborn health care and retain the NHM's energy and focus that brought success to date. Then the other one is that we need to make sure that the reduction in inequality in NMR was less dramatic than the reduction in inequality for service coverage. I just want to explain this a bit in the sense that, say, in 2000, the NMR among the poor was 26 points higher than that for the rich, which got reduced to 22 points in 2017. So 26 to 22 points reduction in the NMR between the poor and the rich between 2000 and 2017. In comparison, the institutional deliveries among the poor was 71 percentage points lower than the rich in 2000, which got reduced to 21 percentage points. So 71 to 21 versus 26 to 22, right? So what you see here is that although there has been an impressive increase in institutional delivery among the poor, their survival chances have not reduced as dramatically, suggesting that the facilities that the poor and the rich access probably are not of the same quality. So thus increasingly, women and newborns are gaining access to care, but not always getting a full life-saving potential of this care. So going forward, further maternal and child survival gains depend on improving the contents and quality of care that is being accessed by both the rich and the poor, and largely in this case, the poor people. So another learning, which I have not shown in the data here, is that the higher mortality states, they were successful in reducing neonatal mortality because they reduced deaths on days 3 to 27, which required reducing and managing infectious diseases. The next frontier for them is to improve survival in the 0 to 2 day window, which occurred more in lower mortality states. So to continue reducing mortality, these higher mortality states have to focus on averting deaths during the 0 to 2, basically focusing on intrapartum and immediate postpartum intervention care. So these are some of the lessons that we kind of like to highlight. This one I would skip for interest of time, and this one is important in the sense that though we see a reduction in inequalities between the poor and the rich for both institutional delivery and C-section delivery, we're still not there yet. Particularly, we see that the C-section rates increased in both the groups, but still tell a story of extraordinary inequality. That is 9% among the poorest. They have access to C-section, which is basically indicative of inadequate access, and more than 35% among the richest are using C-section, which is indicative of heavy overuse for non-medical reasons. So as inequalities in coverage of life-saving maternal and neonatal healthcare reduce, special efforts are required to leave no one behind. To reach the unreached, the policy should be locally informed, universal, and specifically designed for uptake among the marginalized, and focus on increasing the geographic accessibility of MNS services and community-oriented approach. And I thank all the contributors for this study, and special acknowledgements to Ministry of Health and Family Welfare, Government of India, the steering committee, technical working group, and also Countdown and other contributors to this. Thank you so much. Over to you.
Thank you so much, Dr. Ramesh. That was fantastic. It's a lot of data, so I'm sure everyone's just taking a moment to process. But do we have any immediate comments that we can field right now, or any points for clarification that people would like? Rupsha.
Hi, Professor.
You can also introduce yourself.
Yeah. My name is Rupsha. I am a first-year PhD student in global health. When I was reading this article, I was wondering how you decided to do the clustering. Were there other factors that you had considered and thought this might be the best approach? So I was wondering if you'd clarify.
Yeah, I mean, so thank you for the question. I think this is an important question in terms of how do we decide, these two clusters are higher mortality and lower mortality. As I was saying, what we did was that in 2000, I wish I had that map that figure to show you. If you plot the mortality, maternal mortality, say for example on y-axis and per capita income on x-axis, say for 2000, you clearly see two distinct clusters of states in India. It's a scatter plot, right? So, and you saw that naturally some of these, some of these states had lower per capita income, but they had higher mortality. And naturally, there was clusters of states which had higher per capita income and lower mortality. And same thing was actually, you won't believe that for both maternal mortality and neonatal mortality, and also for 2000 and 2018, these clusters, they held good. Very few changes in some of the states. So that makes us believe that, I mean, that's the reason why we wanted to, that's one of the key factors that we looked at, mortality and per capita income. And now everything else falls in place, right? Because your economic development, you're different and mortality is different. So then it makes sense for us to kind of study deeper into what exactly they did in terms of health, in terms of influencing this mortality. And within these clusters, states were similar in terms of per capita income. So economically, they were similar states. But then did they invest more? Did they do more things? Or and the higher mortality state clusters, which are poorer, did they do less? Or what exactly happened? So for us, it was important to look at and control for economic development and mortality. And hope that helps you too. And generally, we believe that, right? So when you have an overall economic development, many of the social development indicators also follow some of these things. And you are right to assume that these lower mortality states, if I compare that for education, so let us not look at per capita income. Suppose we take women's education. It would have exactly reflected the same way because there is a huge correlation between per capita income and the women's education that we see there. So, and we use per capita income because globally, when we identified exemplars in the 7 countries which I was referring to in the initial slide, there we looked at per capita income and mortality. And that's why we wanted to use the same approach even in India to identify clusters of exemplars. I hope that helps clarify that.
Yeah, great. Thank you.
Great. And you guys can keep passing around that figure so everyone can take a look. We have a printout of that figure you're referring to.
Oh, okay. Thank you, Kerry. This is wonderful. That's helpful.
I have a related question, actually.
You can introduce yourself as well.
My name is Michael. I'm a PhD student here. And related to the question that was asked earlier on, it seems to me that, you don't have the data in front of you, you said, but in developing such clusters, the outcome here seems rather extreme. There doesn't seem to be a gradient between the two extremes, and I was wondering whether you could comment on that the Indian economy is such structure that you can either have these extremes.
Yeah, I think historically, if I look at these two clusters, things have been, the trajectories of change have been very different, and largely because of the history and also the way Indian governance is structured, right? So we have state governments and the federal government, and most of the development related factors like health and education, they're under concurrent list. So the states have their own initiatives to, kind of take programs and policies to influence education and health. And historically, most of the states that are in the lower mortality state cluster have been investing a lot on education, particularly women's education. For example, in our, when we did the in-depth study of 6 states, we clearly see that, for example, Tamil Nadu and Maharashtra, which come from the lower mortality state cluster, they had invested on women and women's education and social empowerment, community work, and also, like local governance, historically, even 20, 30 years back. Whereas the higher mortality state clusters, which are largely, had been economically not so strong, they had, historically have not really emphasized the women's education or social change as much as the other clusters did. So what I would say is that so these are deep-rooted differences that we see there, and quite. I mean, there's a lot of history to this as well. I would say that both the policies and the historical trends, they probably make these two clusters differ. Even today, we see a huge difference. Like I come from a village in one of these lower mortality states. And I also saw in one of the higher mortality states in Uttar Pradesh. I lived there. And I see that the villages, my village now, and the villages I see in Uttar Pradesh, they're almost about 20 years apart in terms of the development or in terms of the social norms and the way women or families function. So that's what I think that there is a time lag within India. So India is such a vast country and with a lot of history, a huge difference that we find. And I'm sure it's not just for India as a whole. Many countries would have similar, kind of differences within their countries. But India stands out because of its vastness and clear-cut historical trends that we see. I hope it's a long answer,
Yeah,
but
a lot of nodding in the room. People thinking about these clusters, maybe from other countries too. Do we have any other questions? Oh my goodness, many. So maybe we'll just go in order. Meenakshi and then Dr. Vail.
My name is Meenakshi Das. I'm also from India. My question is about the community health worker ASA. Under how many villages actually been under one ASA? And what are is that the incentives or the salary have been proposed by the government of India to provide them? What I heard actually 3 years before in Kerala, the state government had planned to provide them salary. And the last question is, under what programs they are, under what community programs they are covering ANC coverage?
So, I mean, this is an important question, Meenakshi. And this is recent in the sense that NRHM introduced these ASHA programs. And so as per the guidelines, there has to be one ASHA per 1,000 population. So for every 1,000 population, so that means that if I have a village of 5,000 population, there would be 5 ASHAs. Right, but if there is a village of 200 population and which is also maybe linked to a larger village, and there will be kind of the ASHA would be have to kind of, so we call it as satellite villages, right? So they would be, so generally the ASHA deployment recruitment is 1 per 1,000 population. Now, but this is the guideline, but it varies again by state. And if you see, for example, in the higher mortality state clusters, they have been having difficulty even to recruit ASHAs. And there has to be a lot of, conditions were relaxed for the higher mortality state clusters, because you may not be able to find a woman who is ready to work for the community and has certain qualifications. And it may be difficult to find them. So you may have in a higher mortality state cluster, the ASHA may be covering around 1,500 to 2,000 on an average population, whereas in the lower mortality state cluster, you may find 1,000 or less than 1,000 one ASHA there. The second one is that in terms of payments, so as per the NRHM guidelines, the state government has a prerogative to fix the incentives. So it is not a fixed salary. It is based upon the performance of the ASHAs. For example, you may say that, okay, I have 200 rupees for institutional delivery, or 700 rupees for institutional delivery, and 200 rupees for antenatal care, and 500 rupees for immunization for every child that the ASHA immunizes, right? So that kind of a thing. So it's a kind of a piecemeal incentivized scheme, and roughly, we did a lot of there is a lot of studies done to say that an ASHA would earn around 5,000 rupees, which is I'm very poor in converting that into dollars. Per month. And again, it depends a lot on which state you are in. In a state which has a very low fertility, you have very few chances of making more money because there are not many deliveries happening, right? Whereas in a high mortality, high fertility states, you may earn a little more than what an ASHA in a lower mortality state would earn. But there is a movement from the ASHAs to organize themselves and saying that, can we make this a regular employment for the ASHAs and have the salaries paid on a regular basis? Some states, for example, Rajasthan, has a fixed amount and a variable amount for the ASHAs. So they have some fixed part of the salary, part that the ASHAs would get, and variable according to what they achieve in terms of their outputs. Now, which department? This comes under the health department, health program. So it is not a village development program or something. This is specifically, ASHAs are meant for the health program. And so they cover varied health aspects depending upon the state. From RMNCH for family planning, immunization, HIV/AIDS, TB programs, and now also for water, sanitation, and those kind of things are also ASHA is being used.
Hello, Dr. Manjappa. So I'm Kadirvel. I'm also a PhD student. I'm basically, once again, I'm also from India. So I have dozens of questions, but I will inquire with Kerry because she is also part of the team. But important question is use of the methodology related questions. One is the ANCQ, the composite indicator, which has high correlation between each other. So, and then whether is it actually kind of right, and what are the limitations to use such kind of highly correlated independent indicators together and as a composite indicator. Second is, what is the limitation of this Jane's decomposition methodology used for this particular analysis?
So important questions, really. So antenatal ANCQ, the composite index, you said it's related to the HRH?
No, this is highly correlated because a person who is attending a facility for the ANC coverage, there are high chance that they will be getting a BP measured, the high chance that they will be seen by a stillbirth attendant, there's a high chance that they'll be getting a tetanus toxoid injection, and there's a high chance that they'll be getting a weight measured, abdomen examined on the same sitting. So
I got it. I got it. So the ANCQ, if you, I think it's there in the printout probably. So we looked at the trend, right? So the earlier, initially when we, if you look at the antenatal, care data. So one second, let me. So there is a. there is a trend in the sense that previously the antenatal quality of care, antenatal care was only about, so we have a score of maximum of 13 points in that ANCQ composite index. So in our analysis, say in 1997, only 38% of women in India received ANCQ, means they had 4+ ANC or by a skilled provider and their BP and HB measured and all of that. But in 2018, that value increased from 38% to 85%. Right? So that is what I think is, so it is of course dependent on whether somebody has gone to an antenatal care or not. And whether, so definitely there is a higher chance if you're not going to antenatal care, there is no chance that, a BP can be measured or anything like that, right? But then what we're interested in is the trend. So like in 1997, if only 38% had received antenatal care of a good quality, that's 60% of the 13, the score, and now it is 86%. So there are certainly more people have come, definitely, but also the quality, the content has also improved, right? So what I'm saying is that the conditionality of attending antenatal care applies to 1997 as well as 2018. It's the same group of women who attended, but then what they received in the antenatal care in terms of content, that's been very different. And it is enhanced drastically in the last 2 decades. That's what this analysis shows us. And the second question was, I kind of forgot. Can you repeat?
Yeah, the limitations of
limitations of Jane method. Yeah, so Jane's method, this method actually classifies the effects into fertility-related impact and safe motherhood impact. So the problem is that one of the limitations is the assumption that the residual of those, the mortality reductions that we see is wholesale attributed to the maternal and child health interventions, which is because there is no way the model uses anything related to coverage. So you cannot expect, to assume that, okay, rest of the things are all because of this. It could be because of various other reasons. For example, shifts in causes of death, for example, right? So those kind of things are not taken into account. And all of this is attributed to programs, which is a kind of a limitation in Jane's method, which they themselves kind of narrate that in the paper that they have proposed this methodology. So that is clearly but then that's a small limitation because we are not looking at so much the residual, but then what is that is attributed to fertility decline. I think this was one key method that globally, I mean, we use this in all other countries as well, saying that this is probably the best method to kind of isolate the effect of fertility on MNH.
Yeah, thank you. Just a small correction. I think as of now, the health is still a state subject. It's not in concurrent list. So just what out
it is. No, it is. It is concurrent list. I will give thing like, for example, you have a state budget as well as most of the health budget from the central program, like NRHM, comes from the state, from the federal government, not from the state government. And the state government spends only on, for example, personnel and some of the infrastructure costs like nurses. So NRHM, for example, ASHA payment comes from the central government funding, whereas A&M funding comes from the state government. I'm just giving an example. So it's still a concurrent, kind of budget item. And each state has both the state and the central government component in their budgets.
Yeah, so financially, yes, but constitutionally, still it is in state subject. Education is changed to concurrent list, but health still is health is still in the state subject only. Of course, the federal government expanded their arm, and then especially through the financial powers, they've actually providing all these supports, but still it is a state subject.
Oh, I need to check that again. Thank you anyway. Let me go back and check it and correct.
Latika.
Hello, Dr. Ramesh. Thank you so much for your presentation. I'm Latika. I'm a PhD student in global health as well. I know we are out of time, so I'll make this really quick. I had two questions. So one about whether you considered global influences in your analysis. So during the time, especially with the acceleration and decline, did you think about the Millennium Development Goals and the Sustainable Development Goals in that analysis? And then the second question, so it's really interesting, the differences between these clusters. And I wonder in just sort of your conclusions and recommendations, whether you thought about policies that maybe focus more on socioeconomic factors for the high mortality clusters is maybe a better direction rather than more health policy. And yeah, any thoughts on that?
Excellent questions. I mean, these are all, kind of very insightful questions. Definitely. I mean, the first one, I think Kerry is definitely in a better position to give us a sense, because when we had our key informant interviews and the documents, one of our key questions were basically that did global, India is dependent, used to be dependent on a lot of global funding, right, support for funding. And WHO and UN agencies, UNICEF, they all influenced a lot on India's policies. Generally, whatever is the global policy that gets implemented there. And so how much of that influence, made so when we talked to the key informants and our, roundtable discussions, this thing came up basically. What was the kind of pressure or influence of the global trends, and we see that the NRHM component definitely had a lot of inputs from the international development partners within India, and they contributed a lot in terms of what should be the basic components. But then I think the game changer was this kind of a political commitment within India to invest their own money into the health sector and giving a lot of flexibility in the use of these funds. So that really was a game changer, according to me. And if you look at now in the countries in Africa, for example, they're so much dependent on international donors. And then the domestic spending on health is so. Now USAID closing down their businesses. So we are looking at now what would be the impact on health sector, say in Nigeria or Kenya, and HIV or MNCH work and family planning. So India used to be dependent on many of these kind of international donors earlier, and I think with NRHM things changed a lot, and I think India started investing its own funding, its own money into health. So that was a game changer. The second part is the competing, kind of factors such as overall economic development. So we looked at that economic development aspects also. We knew that, India progressed not just because of health investments in health or changes in health policies and programs, but underlying socioeconomic development that has happened, changes that have happened, cultural changes have happened in India. And they were different in different clusters, as you were right, assuming that in the lower mortality state clusters, they were in a different trajectory of, for example, electricity or school enrollment was much higher, 20 years ago, where the higher mortality states are currently now, right? So we did analyze all of that in our report. The problem was that how do you kind of put all of this in a kind of a analysis of a, like people would like to look at decomposition analysis, and we tried all of that to see whether we can attribute some of these changes in mortality to changes in, say, socioeconomic development, like electricity, road construction, mobile phones, and those kind of infrastructure changes, versus women's education, versus institutional delivery increases or antenatal care. So The problem is that we don't have all the data and methodology to actually decompose this. And we did analyze that, but then we were not convinced with the results. So we had to abandon that in between. But it's an important question, and we looked into that in our detailed reports, and I would really encourage you to look at that and see. And it's a methodological question, actually. How do we incorporate that in our analysis in a quantitative way?
Thank you. Oh, I wish we had another hour because I think there's still more questions. But thank you so much, Dr. Ramesh. That was a wonderful presentation, and I think everyone can join me in a round of applause. And I'll turn the camera.
Thank you.
We'll close here. Thank you so much.
Thank you very much, Kerry, and thanks everybody.